We originally were going to do a quote spicy debate, but decided in this horrendous political climate, there is much to be said for respectful dialogue, and that's what we plan to present. I'm Michael Bierer, Mass General, been doing primary care and addictions for longer than I'll admit. You can, do you want to introduce yourself now or later? Okay.
Well, we both are wearing bow ties, so want to make sure everyone recognizes that. There are other bow tie people we respect. Thank you. My name is Stephen Martin. I'm a primary care and family medicine, addiction medicine specialist at MASAM Bierer Family Health.
We have no relevant financial conflicts, potential or otherwise. We have a few learning objectives. We want you to be able to summarize the historical and contemporary epidemiology of illicit and non-prescribed benzos, characteristics and prevalence of benzodiazepine use disorder and misuse, and the definition of misuse. We will appraise a set of case studies concerning benzodiazepines. We'd like you to be able to name 2 benefits and 2 risks of benzodiazepines that these case studies demonstrate. And then through our discussion today, we would like you to be able to develop 1 concrete strategy that you will bring to your practice to begin to or solve a problem that you might be harboring. I mean, I guess one of the first questions is, we are not going to be discussing sort of general primary care benzodiazepine issues. I mean, we're not talking about 70-year-old with insomnia. And we're generally discussing pretty complicated clinical situations and not only prescribed use of drugs, but use of non-prescribed drugs. Anyone have any feelings about benzodiazepines? Building on Dr. St. Louis's introduction, there's a lot of, especially where I think the evidence is lacking, there's a lot of strong feeling, and we need to acknowledge that we're taking care of difficult situations, and no matter what decisions we are making, somebody will disagree with us, and we need to be respectful about those disagreements and know that we are all working in good faith to do the best we can. For you.
Oh my gosh, yeah. Briefly, please. Yes. The conch shell, oh my God, let's not go there. No references, please, to Piggy or others. Yeah. I do want to, just in Michael's stead, give some additional context, which is there is an evidence base. And we are going to be very deliberate about sharing evidence. Like, this is not a I feel talk, because I feel as a clinician is not great for my patients sometimes, or for us around an entire medication class, to my mind. So this is going to be, how are things looking, individualized care, and just to lean on the wisdom of Dr. Hernandez this morning and Dr. Hubert, who is acknowledged and honored. MASAM, this is a tough subject. Like, we're going to look at some hard, if this was easy, we would not be really talking about it. But just like MASAM has looked at drug testing, methadone dosing, non-abstinence care, chronic pain, this is an important topic that has received in conventional wisdom that we hope to sort of shine a light on. So that said, W.H. Auden, The Age of Anxiety, 1949. Anxiety has been part of the human condition forever. If you know your evolutionary biology, that's how we all got here, basically, is we're anxious about something. And by being anxious about something, we got to survive and fight another day. So the problem with anxiety disorders, I would say, as we experience them, is that anxiety disorders turn this up to 11. So what was evolutionary benefit is now not a benefit, and it's actually very much interfering with somebody's life. And that's why it becomes a disorder. That's why it's generalized anxiety disorder that we'll be primarily talking about. And I would just ask people to think about, how they would, the idea of what that feels like, and how people don't like being anxious all the time. And not all of it is structural determinants. Some of this is endogenous disorder, and to recognize that. So the medical context, as mentioned, this is part of the human condition. It was the focus of some of the initial psychotropics in the 1950s. We know the story of diazepam and Milltown, and upwards of millions of prescriptions at that time. Really, there was a backlash in the 70s when people realized, oh, you could become dependent on these. And I just want to be clear, that was the backlash. The backlash was not people were falling over in the streets. The backlash was, oh, I'm having a hard time getting off these. Just to hold on to that, please, okay? Because it turns out we prescribe other things that are hard to get off, and we do it without much judgment. I'll speak to SSRIs and SNRIs as an example. However, we sort of fooled around with the definition and the nosology of this. In the 70s, anxiety and depression were essentially separated. And I think it's worth thinking that this made anxiety sort of the second fiddle to depression. And yet, in doing that, it also made depression a target for pharmaceutical companies who no longer had patents on benzodiazepines, but were pretty psyched about Prozac and SSRIs and SNRIs and the next 17 lookalikes that they all had under patent in Canal study. And guess what was left out of those studies? Something that nobody had a patent on, benzodiazepines. So this question of like, oh, I wish there are no studies. Well, there aren't any studies for a reason. Nobody funded those studies. And that is the market speaking, going back to this morning's discussion. So now anxieties are 40 million people in the US. It's the most common mental health disorder in the country. And it's generally had less of a focus than depression. I don't know if people, I don't know what your sentiment is, but that's my sentiment. I think it's borne out, but not for good reason, because it turns out in these studies of mortality risk, that if you have just anxiety, I'm putting that in quotations, just anxiety, the A in these graphs, that is your mortality risk is twice or more baseline. So just having generalized anxiety confers a reduction in life expectancy and increased mortality. If you combine it with AD, if you combine it with depression, that's rough, but I guess I don't know of any patients I have who have both generalized anxiety and depression, so that must be a pretty rare circumstance. But all the more so, let's be very careful here to say, look, depression, don't like that. It's really hard, and definitely that's part of my focus with patients. But anxiety should not get left behind. And it really has been, because there's been no, again, incentive to focus on it from either from a pharmaceutical perspective. So let's just look at what we do treat anxiety with. The first line treatments are CBT, SSRIs, SNRIs. Why is that? It's because they were studied. Why is that? Because they were under patent. Why? Except for CBT, which has a whole other constituency, thankfully, supporting it and helping it. The number needed to treat for each of these is 4 or 5. And this, going back to our clinical epidemiology, that means that 80% of people will not benefit from these first line interventions. And David Ortiz was one of the best clutch hitters in baseball and for the Red Sox. He hit 338, I think, as a lifetime average. But if he had hit 200, that would have been so good. And that's really what that's what these are doing. They're hitting 200. And guess what? People's anxiety does not go away because their agent that we tried didn't work. Sort of like, oh, I'm sorry, it didn't work. Okay, but you don't have that condition anymore. So it also turns out that withdrawal from these very common medications also has significant effects for some people. And they also have side effects that we either paper over or don't discuss, but that's why people stop. These are just some to sort of bolster the sense that the conventional wisdom that benzodiazepines are a poor agent for medical care is contested. And so the first is here from 2005. This is a recognized and disdained, appreciated and attacked class of medications, which may sound like another class of medications that we also think about. But it's very weird. And we'll go into the epidemiology. Why do we have feelings about a medication class in this way, as will unfold? It turns out that people don't escalate their dose. They really generally don't lose therapeutic effect over time. I can't think of other medications that are like this. And this is from 2023. And then in 24, this is in some ways, for some people, I'd offer an ideology more than an evidence base. And that is, quote, have fueled an anti-benzodiazepine movement. And when you fuel a movement in an evidence-based profession, those don't mix well together. Unless it is also evidence-based. But as Dr. Bierer will show you, it turns out that a heck of a lot of people seem to still getting the benzodiazepines in the US.
Tag team. There are a couple of publications that summarize the epidemiology of benzodiazepine use and prescribing. There are a huge number of benzodiazepine prescriptions out there. Something like 10% of US adults are using benzodiazepines. This is kind of crazy. The people, let's see, the development of a benzodiazepine use disorder is a fairly rare event for people being prescribed or using benzodiazepines. However, I think we're missing one of the slides. This one. 12.6% of adult Americans used benzodiazepines in the last year. In this one NSDUH summary. 10.4% use as prescribed. 2.2% of Americans use them, are misusing. And what is misuse? It is prescribed, using other than as prescribed, using for other reasons, or using non-prescribed. And of the misuse classification, about 3/4 are using non-prescribed benzodiazepines, receiving them from friends, family, or buying them. But they don't necessarily have dependence. And they may have physiologic dependence, but they don't have a substance use disorder. There's the one French study of people prescribed opioids. There were a vast majority were co-prescribed benzodiazepines. People without severe mental illness, lower rates of prescription. People with severe mental illness in America, 42% are prescribed. Boom, 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 1 minute. What? Oh, I see, you're keeping us in train. This is beautiful. I think I went over this. Do you want to do this? Oh, this is, why are people misusing benzodiazepines? For sleep, for relaxation. They're for therapeutic purposes. And now I think this is yours. Yes. So EPIC is on your mind.
Oh gosh, on a Saturday no less, but we never look at EPIC on Saturdays. I know this is an unusual situation, but just bear with me for a moment, because this is a best practice advisory. And again, just to go back to this prior slide here, to highlight we are an addiction medicine society. Benzodiazepines have on the order of 1% conversion to a use disorder. Why are we discussing this? And I think the framing actually isn't that people develop a use disorder of benzodiazepines, it's that our patients, a lot of them use benzodiazepines. But we should be very cautious that we're not here because of an explosion of benzodiazepine use disorder. That has never happened in 50 years of prescribing. We should be, if it hasn't happened by now, it's pretty hard for it to happen. So let's just keep that in mind if we could. So I saw this yesterday, I think, because I'm prescribing both an opioid and, a buprenorphine in this case, and I get a best practice advisory, and the default is to remove one of them. So that's actually what it says, continue discontinuing the benzo or opioid order. Well, it's not really considered, it's like defaulted to it. Like if I press one more button, it'll go away. That's the default. And I just want to point to this. This is not individualized care. This is, and we'll get into it, why is this here? So this would mean you choose. I think people don't have any effect if you just immediately stop their benzodiazepine or you stop their buprenorphine. But that's what my medical best practice advisory is. But it turns out that even the FDA says not to do that. And the FDA, and in tip 63 from SAMHSA, for such patients who are doing fine, tapering benzodiazepines may be contraindicated and unrealistic, which I think it characterizes many of our patients. But if you're on a full agonist, the reason I get this is because of a black box warning from the FDA in 2016. And just to speak to that, one of the, it was very kind of Natalie to mention our paper on dosing and buprenorphine. And the part that the amateur medical historian for me was going in the deep dive in the FDA documents. And at each point, what was the evidence and what was the FDA saying? And it turns out that's our revelatory approach. And so I'm going to do something a little revelatory here, at least for me, which is that FDA had 6 studies it looked at with a black box warning. That's as heavy as you can go. These 6 studies, you would think, would have to show that prescribed opioid and a prescribed benzodiazepine taken as prescribed lead to higher levels of death. That's what that black box is, to me, as a clinician. That is not any of the data they had. These are the 6 studies. They were all associative or based on epidemiology of prescribing. But not one of them goes to the question that we just posed, or I posed. If someone takes a prescribed benzodiazepine and opioid as prescribed, do they face a higher mortality rate? That is not answered by these 6 studies, and these are the only 6 studies in the black box warning. There are some really good studies here. Thank goodness I'm not glad they're out there, but it may turn out that instead of taking a prescribed benzodiazepine and a prescribed opioid, taking an opioid like fentanyl and a benzodiazepine may not be good for you. But that's, again, these are the 6 studies from the FDA. So just what might be the potential benefits? They could include that they're effective. This is from a network review in 2019. They show longer retention and mood, especially with buprenorphine, and they're safer than a non-prescribed benzodiazepine, we'd say. Well, what are the risks? And let's just sort of walk through them. Do they lead to dose escalation? But they don't. Do people overdose from only a benzodiazepine? No. Lethal dose 50 is like hundreds of milligrams a day. And so the overdose from a solely benzodiazepine is considered, even in the guidelines we'll look at, a rare event. Do they have adverse effects? They do, absolutely do. Do they lead to dependence? They sure can. Physiologic dependence, to separate from the old school addiction dependence. How about if they're used as prescribed as a benzodiazepine, can they lead to increased overuse death? And I had a chance to review this for a paper from 2018, but there have been successive studies. This study is well done by Ted Park and others when he was at BMC. Just want to look at the numbers though, because this was 64,000 patients on buprenorphine, of which 31% also had a benzodiazepine prescription. And look how good buprenorphine is. Only 183, 183 is too much. But out of 64,000 people, 183 people died of an overdose. And of those, 42% had a benzodiazepine. But now we're looking at single figures out of 64,000 patients. And so just want to give sort of the relative approach and magnitude of what we're discussing. And you're in luck because now Michael will take
over. So we are of the benefits of benzodiazepines, the amelioration of anxiety is very good, but that's short term. So there are other things that we give for anxiety. They may not quite be as successful, certainly short term. Lots of pages here. Okay. So here's a case. We'll be asking for some feedback and discussion for these different cases. 28-year-old who meets criteria for generalized anxiety disorder, and SSRIs have caused suicidal ideation. They, the singular pronoun, have a counselor and has tried cognitive behavioral therapy and other modalities which have not been helpful. They're finding it increasingly difficult to be in public life, to work, to show up. So they want a benzodiazepine prescription. What are you thinking? What's the next step discussion? So counseling about proper use. They're asking for a benzodiazepine, so by definition, they're asking for a drug. They're other med seeking. Why mention benzodiazepine if they're benzodiazepine naive? You know, so there, one prescription is not necessarily like another prescription. Right. They want relief of, they want to be able to function better. So what about this scenario, but the person also has an opioid use disorder? Change your thinking? Are they stable from the, or are they being treated for opioid use disorder, and are they stable? Are they in remission from that? Right. Are there regulations about what are the options? Other psychiatric comorbidities. Diversion. We are worried about diversion. Did everyone hear that? Yeah. So the idea is that sometimes it is an adaptive, rational response to a risky or impending traumatic life to be anxious, and that would not probably meet criteria for GAD that this patient has. Right. So the hazards of quick diagnosis by undertrained primary care doctor like me. Yeah. Yeah. So I think, go ahead. Yeah. So what I'm hearing is a lot of hesitation to pull the trigger on that first benzodiazepine prescription for a lot of reasons. But I want to move on for time. What do you think? So, and B, this person has used clonazepam in the past, and that has had salutary effects. And they want to, doc, help me. I can actually function with this medication. Uh, how are we feeling about that request now? So the question is, or how are you using this non-prescribed clonazepam? Is this really something that I would like to replicate with a prescription pad? Or maybe I do. Maybe that's a decision I will make. Um, but there is this, I mean, I think that uh, what I share is this feeling of a very high stakes initial decision. Um, and I don't know that we're going to make that go away. Case study two, 32-year-old with OUD on buprenorphine prescribed benzodiazepines for generalized anxiety disorder has had a non-fatal overdose. They're worried that you're going to discontinue the benzodiazepine prescription. Would you, A, continue the prescription? Assuming it was an opioid. Do we know? Yeah, it was fentanyl. So again, there's a hierarchy of benzos. We like some, we don't like others. For good reason? Um, Probably, yeah. Recall that the prevalence of non-prescribed benzodiazepine use is very high. Probably in the, I don't know, overall of all benzodiazepine users, probably. Right. Has the benzodiazepine use escalated? I'm sorry, I didn't hear you. Right. What is the adherence like? What are they actually taking? Missing doses, too many doses? Are they uh, going without and having rebound symptoms? Um, so general discussion of safety and what's the tenor of the patient's life, and are there negative effects of this of the benzodiazepine prescription? Was the fentanyl use self-medication of something other than just rampant, out of control addiction? Right. So the question, the concern about driving a patient to the street and an unregulated drug supply. So I think many of us think just stopping the benzodiazepine might be a bad idea. So I think I will go to you. Yeah.
Why not?
Yeah, because
we're here.
And we're staying on time. We're staying on time.
Adam hasn't rushed the stage yet, so this is very encouraging. To frame our next case, the final case, there is something in the constellation of what I just heard in the thoughts in the audience, that there is something of a harm reduction approach in 2025 when we don't live in a bubble and people only take things from me. And I think we need to grapple with that, because we seem to have an easy time of harm reduction in other ways. But what if a safe supply of benzodiazepine is its own harm reduction? That would be a very off-label use. No, but it's not, no, it's still being given, no, it's still being given for generalized anxiety disorder. It's just that your calculation of risks and benefits, I think all of ours should have changed a while back. And when we ripped a bunch of people off of opioids who were still in pain, and guess what? They still found something else. So just putting that out there. So why would people in Vancouver have an entire Delphi gathering on what this particular strange phenomenon, managing benzodiazepine dependency arising from the adulterated opioid supply, a Delphi technique? Why would a bunch of wonderful colleagues in Canada have to talk about what to do with benzodiazepine dependence in people using from a street supply? They have synthetic benzodiazepine in the supply. Somebody tries to stop and get on mood. They do, but now they're withdrawing from benzodiazepine in the supply. They no longer have access to. And to the credit of these Vancouver and British Columbia colleagues, they are grown-ups, and they had a very good grown-up conversation about this person is dependent, and they are currently using street supply, which is lethal. And we are going to temporarily prescribe a benzodiazepine to allow them to get fully on mood and successfully withdraw and come off the synthetic benzodiazepine they never wanted to be on in the first place. This is coming, folks. And I know that people may not think so, but I'm putting a shout out to Maria, who gave a heads up to her Holyoke folks about what was coming down the line, because guess what? It's coming down the line. And the Baltimore overdoses that were experienced earlier this summer were from a synthetic benzodiazepine, all of them. Every last one, 37 people in the hospital. And interestingly, in the emergency literature, it's not people on a prescribed benzodiazepine who get intubated. It's people who are on a synthetic benzodiazepine they never wanted to be on in the first place are the ones that get intubated. So this is, this is high stakes stuff. And I think it's incumbent on us to think about things in a high stakes way we haven't had to before. So in this case, the 35-year-old can't stop fentanyl because it may be with withdrawal symptoms. Drug checking in the regional supply is finding synthetic benzodiazepines, would you, I'm going to put them all, advise them to hang in there and get through it? Because they shouldn't, prescribing a benzodiazepine to someone who doesn't have generalized anxiety disorder and is just dependent on benzodiazepines, but they can't get on life-saving treatment, like that's a lot of risk calculus to put in one place. But they could check their drug supply and confirm they have been exposed. That's not so easy to do. I love our drug checkers. It's amazing, but it's not really for clinical just-in-time use. And they've already shown in the region that there is more synthetic benzodiazepine. How about using toxicology testing, even though you won't see it? But that would be reassuring, though, that you don't see a benzodiazepine, but guess what? It's a synthetic. It's not on there, but boy, there are going to be some people doing this. And then lastly, deliberately prescribe an empiric benzodiazepine to allow them to taper and get on life-saving treatment. And this is the thank you. This is the thoughtfulness that had to go into this discussion in British Columbia. So, Michael, thank goodness you're up again. So,
the proximate cause, the thing that brought us here was this. This is the ASAM guidance on benzo tapering. Our tax dollars, maybe our membership dues, went to the production of this guidance, which is called benzodiazepine tapering. And the problem, so this was in response to, I think, the FDA contracting with ASAM, an addictions organization, to come up with rational ways to taper benzodiazepines. And so implicit in this heavy tome is the notion that that's the default. We should be getting our patients off of these drugs. And there is some value in this guidance. There's a lot of good reference material. There is some lip service to weighing risks and benefits of stopping and risks and benefits of continuing. And, hearkening back to yesterday's talk about documentation of opioids for analgesia, for pain, in primary care and other situations, really, we're trying to use this document to help us easily talk about risks and benefits in our decision-making with patients. So it's a process that took years. There are many very strong recommendations made by this expert panel. Yet, among all the studies that they reviewed and used for decision making, the quality of these studies were very low, and the confidence of the conclusions was low, but the strength of the recommendations was in many cases high. And that's what we're left with. This has been, these recommendations have been endorsed by many professional organizations. And the default is taper. We should be thinking about tapering for any high-risk population. And I'm honored to be included in that 65 years of age or older group. If we have a comorbid substance use disorder, which is everyone we take care of, concomitant opioid prescription, an exception is made if you document that benefits outweigh risks in yours and your patient's mutual decision-making. They recommend ways of tapering that will take months to years and do describe conscientious and very time-consuming, resource-intensive patient management. So it's a useful document. There's a lot in there, and we'll go over some of it. They talk a little bit about the risks of discontinuing benzodiazepines. And This is one study by one of the members of the expert panel that showed an increased risk of death associated with discontinuation of benzodiazepines. It's a bit of a tautology. High-risk people were perhaps those who had benzodiazepines discontinued, rather than low-risk people becoming high risk because of the discontinuation. So it's an association. It's not a causality, but it is something to think about, and it's in the air we breathe. It's in the black box warning. We are supposed to think about prescribing benzodiazepines as risky and stopping benzodiazepines as risky. So we're left in the hot seat. So they recommend that you discuss the idea of tapering, convert to longer acting benzodiazepines, stabilize the patient, and then negotiate some sort of a stepwise reduction of something like 10% per step, and each step can last for 2 weeks to 2 months. And we're talking about 6 months to 2 years of a taper. And at each step, you're checking for either rebound symptoms or recurrence of the symptom that was being treated or withdrawal symptoms. And if the patient isn't doing well, you can stop the taper. You can go back a step to a higher dose. That's a reasonable and patient-centered approach. The problem with this recommendation is it now standard of care? Is it the base of low-level quality, or is this an aspirational high-quality process that we should be engaged in? And are we putting ourselves at risk by adopting this guideline and saying, this is the standard of care? I'm going to document every step of the way with my patient. I'm going to check in every quarter. I'll document a discussion of risks and benefits, and will keep the patient's well-being front and center in my documentation and in my care. They also recommend that benzodiazepines be sort of the last thing that is tried with a patient after CBT, SSRI, et cetera, and that for each, while you're doing your tapering, the patient is benefiting from, in one of the case studies, they present EMDR and prazosin and CBT and CBTI and on and on. So how realistic is this sort of recommendation about adjunctive expert services for patients? Yeah, so does this elevate our risk of torts? So, I've kind of summarized, I think, what they're recommending as a tapering, or we want to call it an optimization strategy. So you document risks and benefits, although they're not really well known. The risks are not. The benefits may be, the patient may be able to tell you. You want to stabilize on longer acting benzodiazepines, agree on an acceptable taper schedule, agree on a communication frequency, a check-in at each dosage. You may or may not want to document that. I typically try not to document a promise that holds me to a high standard in the medical record. And be prepared to change plans if clinically it's not working out. Slow is better than fast. Small decrements better than large ones. And these steps are each lasting weeks to months. And do we really know what the optimum decrease in percentage lorazepam equivalent doses is? we don't. This is just a table that might be useful of what are the half-lives of different benzodiazepines. The ones with the arrows are the longer half-life drugs that are recommended for the tapering. Smoother, easier. Diazepam's cheap, lasts a long time, 100 hours half-life. And chlordazine epoxide is metabolized to diazepam as well as others. So I don't like alprazolam. So the risk of benzodiazepine withdrawal is not 100% predictable. Longer periods of high doses of benzodiazepines that are taken frequently is a more predictable withdrawal scenario, meaning an abstinence syndrome. The exception to that is low dose, short duration prescription that the patient is taking less than 3 times per week. So less than a couple of weeks, 3 weeks, 4 weeks, 3 times a week, low doses. You don't really have to worry about an abstinence syndrome. There are going to be exceptions, but longer durations of higher doses, and I think they are calling 15 milligrams of diazepam per day a higher dose. So that's a pretty low cutoff for something that they're calling high dose. Both. The acute withdrawal is what the guideline is talking about, but there's some mention of post-acute withdrawal syndrome, which is this months to years of recurrent symptoms that can be quite intrusive and sometimes sudden paroxysmal. And again, the higher dose, longer duration of whatever it is they're taking is going to be associated more with the post-acute withdrawal syndrome. So one of the references in the appendix is a study of a pharmacy based education intervention that looked pretty good. Basically, this is kind of an illustration of something that you might come up with in illustrating to a patient how to reduce dosage. In this case, it was lorazepam tablets. And after 6 months, there was a significantly better percentage of people off completely of benzodiazepines in the intervention arm than in the control. So I put that in more or less just to kind of give you a taste of what's in this massive guideline. There's a lot of information in it. You may or may not want to spend the time to delve.
Yes, you may or may not, but it is right here. We have a copy with the lending library is here for you. So we learned yesterday the importance of not just our clinical decision-making, but making that apparent to others through the medical record. And I hope, we hope, given the preceding discussion and presentation and state of the art, that this is one possible template one could consider and modify as needed. But just to give a flavor of what we've been discussing, we are looking at benefits and risks. The benefits here are evidenced by some we're going to learn from the patient why they're benefiting. If they can't tell us, then that should be a signal. But most of my patients can sort of tell me why they're benefiting. Number 2 is additional benefit includes a safe supply compared with a non-prescribed supply. And you could rephrase that in saying, number 2, harm reduction, which is not indicated, but this person already has generalized anxiety disorder as an indication. And I think we're going to have to be explicit. We're going to be grown up about this. This is the real deal. And things are going to get worse in the supply and more toxic and more lethal. And it'll go up and down, and there'll be less fentanyl, more caffeine, and more starch, and less fentanyl, and then something else will come back. But we will never know. It will never, ever be safe again. So each time we have a patient decide between ourselves and an alternative for an indicated diagnosis for which something they were doing well on, then I think this is a reasonable risk and benefit presentation. Reports taking the medication as prescribed, and as we saw in the evidence, there is no evidence that I could find, with grateful to learn from it, from the FDA otherwise, if you're taking your medication as prescribed, that you have an increased risk of harm. That we reviewed the potential risks with this use, and the patient accepts these. We agree to continue at the current dosage, and we'll continue routine reevaluation, which we underplay. One of the virtues I think we do in our work is that we meet with people in an ongoing way. And if August was a good month, but something else happened in September or October that makes us think about changing something, and the patient gets that too, like, we're going to know that. This is not an autopilot situation. And especially in this kind of situation, really benefits from the longitudinal relationship with the clinician. So, Michael, I think we're going to jointly, or only Michael, do concluding thoughts, I hope. Let's see here. Yes, this is actually the last slide, but I hope this has given you a flavor of, again, as Michael mentioned, this is prompted by this joint guidance on tapering. And in this, the subtitle is When Risks Outweigh Benefits. When risks outweigh benefits. And that is the calculus we're wrestling with in a lot of our work. And we hope that today you've seen some of the straight out evidence of benzodiazepine and long-term benzodiazepine use in the United States, and that this might help inform your thinking on evaluating those. Thank you. Yeah, Q&A or discussion, or speak your piece, speak your truth. Yes, into the ice cream cone, please.
I hope I do this
so few
correctly,
bunny
or it'll be
pictures
very
here.
embarrassing.
It's embarrassing.
I know, it's terrible. This was really excellent. One question I have, it sort of seemed to me upon reading the ASAM practice guidelines that they were just sort of regurgitating the Ashton manual, and the disparity between the level of evidence that they had and the way they wrote their recommendations was actually not in line with how up-to-date says we should do it, right? That, like, the actual words recommend or suggest and whether or not we say strongly should correlate directly to the level of evidence, which they just chose blatantly not to do. And I guess I'm interested to know whether anybody has any insight for just how this came about at all. Because it really seems sort of so contrary to some of the other great, I think about the stimulant use guidelines that ASAM put out a year or two ago, which really were thoughtful and pragmatic and tried to integrate the little evidence that we did have into, like, how do we actually take care of patients? And then these sort of fell from the sky from some other multiverse that I don't live in, and
I want to go there. Yeah.
It just sort of seemed almost like, did anyone on the expert committee ever take care of someone using benzos? Like, it just didn't feel like reality. So
yeah. So Josh, thank you for this. And look, I think what I love about MASAM is, what's the history here? How did this happen? Why are we doing things the way that we do them? And so in short, I'm a member of the Quality Improvement Committee for ASAM, which has to vote on these guidance. This guidance came to ASAM to be the convener from the FDA. And my understanding from the FDA's perspective is that the FDA was seeing a tremendous number of complaints from patients that they were being cut off from their benzodiazepines precipitously. And the FDA, understandably, to their credit, was worried that this was not good practice and harming people. And so the intent, the framing, I think, that of the guidance that I find helpful is, when the risks outweigh the benefits, consider this tapering, and do it right. Do the tapering well. If you're going to taper, don't do it on sloppy. Okay. And I think that to me is sort of the gestalt of the guidance is, please don't do tapering badly if it's indicated. Yeah. Sorry, I know there were.
Yeah.
I'm sorry. Hi, Phoebe. Yeah.
Four questions, but I'm not gonna ask all of them. I'm gonna they could be your next presentation. Only one do I really need an answer to. Okay. So one is, what if, and this is a thought experiment, what if maybe one of the reasons not to prescribe benzos is by definition the fact that it is so hard to get people off it that by the time they are 50, 60,
Yeah.
and they start having cognitive decline.
Okay, so I'm going to speak to that, please, because it's an excellent question. So Lewis Carroll, Alice in Wonderland, jam tomorrow, never jam today. And what I would challenge there is someone's not able to go to work. They're not able to be with around people. They're too scared to do anything today. And so planning for something decades from now that may or may not happen is interesting, but also may not be their calculus for what they have as needs. And we put people on a lot of things that they become dependent on, and we're not so challenged by that. So, oh yeah, I mean, SSRIs, I've had a lot of disasters with SSRIs. People want to get off. It's very much in the literature. Okay, fine. We're happy to share the data. It's okay.
To see some studies about the whole safe supply argument, which is made a lot about that both benzos and opioids, which like as a harm reduction. And then also, what about benzos in people who have known chronic benzos and people who have known alcohol use disorder, not talking about tapering. And then also, what about the evidence that shows that benzos worsen PTSD, which many of our patients have as a co-occurring disorder with anxiety? You don't have to answer all those, but maybe in an email or something like that.
When we, in the interest of letting a few more people ask questions, let's do that. And then, because we're getting close to we can continue.
Feel free to stay.
We
Feel free
can
to stay.
continue
This is
to
good
talk.
stuff.
This is a,
Yeah, this is your world right now.
right,
We're glad to be there with you.
right.
Natalie Stahl Lawrence. First of all, I wanted to give a plug on the benzodope question. There is a podcast from Crackdown. I don't know if you guys know about Crackdown, but it's from British Columbia. There's an episode called Love, Death, and Benzodope, which is about, it's a very moving episode. So highly recommend if you want to know more about benzodope, listening to that. So I guess my question was similar, but in terms of if you are agreeing to start, my inclination is often to say I would prefer to start PRN rather than like starting a daily benzo. And is that something that you guys do if you're deciding to start it? Because usually my concern is not just like 30 or 40 years down the line. It's like, I don't know how long I'm going to be at my institution. My patients have chaotic lives. There's going to be disruptions in their care. Like they have a high risk of benzos being discontinued, whether or not, like, it's not like my patients have stable lives. They're going to be in my practice for 30 years. That's not the lives my patients live. So that's my question.
So I can count on one hand the number of benzos starts I've done for patients who are truly benzo naive. I mean, there are a lot of patients who are on benzos for one reason or another come to me. And I think it's a reasonable, the question is, should we start by dipping our toes in with PRNs rather than standing? And I don't know the answer to that. I mean, I think it's a stylistic issue and probably patient dependent. I do want to say that I do have, in the context of alcohol use disorder, my my fellowship director, John Renner, said, for someone who's recovering from alcohol use disorder, you can prescribe a benzodiazepine, but your back has to be against the wall. It's the last thing you want to do. And I think that may make sense in terms of what's going on with the whole GABAergic recovery of the brain in that disorder. But anyway. Oh.
I would just say quick, I mean, since we're all here, but I mean, Natalie, I'm with you there. Like I'm just with Michael, just in full disclosure, I started very few people on a benzodiazepine for a night. Because the thought experiment is important. Right. And I say this with rhetorical, transparency. We have to hold each individualized patient situation and affirm it. And I would, if someone was in this situation and they were indicated and they were suicidal from SSRI and they tried CBT and they couldn't get to work and their life was falling apart, I'm lucky to have this medicine to help them. So no holds on there, but I just think in terms of prevalence, I'm just curious about this paradox that we have over half the people we take care of with a severe opioid disorder are taking a benzodiazepine. Why in this room are we so ambivalent about that? Over half of them, that's an extraordinary bit of knowledge to have. So that doesn't happen much in our work. So anyway, I would just say the thing about generalized anxiety is that it's generalized, and PRN is sort of tricky for something that's day in and day out. So I wish that weren't the case, but maybe. So yeah, David. Sorry. I'm sorry, we're next year. I'm so sorry, my fault. Yeah.
Hey, fantastic talk. I'm Jacob, BMC fellow. One of the concerns I always have that I'm either holding or sharing with a patient, whether it's starting someone who's essentially benzo naive or helping someone consider the risks and benefits of their future use if they're contemplative about that. One of the concerns I've inherited is that they're so effective that it will rob them of the opportunity of certain other mechanisms of responding to panic and anxiety. And I think that maybe that's sort of an optimistic and glassy-eyed view, but it's just one of the things that I'm always weighing is like, is this drug so good, to put it bluntly, and kind of intentionally so? Am I losing certain avenues that we haven't truly explored enough yet?
That's a great question that I think generalizes to pharmacotherapy of the behavioral disorder that we treat broadly. If you add CBT to buprenorphine, it's hard to detect the effect of that additional person-to-person intervention because the medication is so effective. So that's the good answer to what you're saying. My personal answer is I agree completely. And people will learn that this medication is associated with the passage of the symptom, whether or not the medication is responsible for the passage of the symptom. That relief is going to be reinforcing. And certainly short-acting benzodiazepines like alprazolam is such a drug that creates its own demand.
Yes, hi, David. Yeah, thank you so much. That was really very helpful. Thank you.
Kind of a little bit of a shift. I was wondering, do either of you or anyone else see any utility in doing assays for novel benzos in certain specific patients? Maybe somebody who's having a peculiarly difficult time inducting onto buprenorphine or something.
So great question here. Is there utility in someone who's having difficulty with their recovery or in their symptoms you're uncertain about, who's exposed to the drug supply? Could you do a toxicology for novel benzodiazepine synthetics? One could, and there are ones that could be specifically ordered. I think the difficulty there is it might be specific, but not sensitive, because we don't know what we don't know. And then you don't know if it's causal or not, if you do detect.
Yeah, on the other hand, it might be the only opportunity you have if it happens to pick it up, to intervene usefully by maybe giving somebody a benzo to get through.
No, thank you. And I think we should, it's worth looking at the Vancouver and British Columbia guidance to sort of see their reasoning for very similar situation.
I just want to say it's now 5 minutes past the end of the day. We're happy to continue this discussion. It's interesting, but you don't feel like you're being rude if you want to get up and get on your bike or go to the beach or whatever it is.
My question is about the synthetic benzos. In this field where we're constantly feeling like we're catching up to the drug supply, is there any action being taken to try to get out ahead of this? Are we actively testing the drug supply now for these synthetic benzos? Are we having our office, based drug testing include those things?
I'm worried about synthetic benzodiazepines, and we have an answer here, though. There's an answer.
Novel psychoactive substances for 3 years. So if you would like Dr. Gordon to present on that next year. Yeah.
So
we
novel
have- we have
psychoactive
data-
substances,
we have data for the past 3 years on
Yeah.
designer benzos.
yeah, so I would, I would say, let's speak directly to this. I'm in Baltimore. I have 37 people overdose due to a synthetic benzodiazepine. And when I listen to interviews with those good folks, a lot of their talk is about Narcan. And I think we have to be, I think the benzodope episode that Natalie mentioned from Crackdown is extraordinary. And on the basis of a single case should give us a wake-up call that we are, to my mind, no way ready for something like this. Yes, it was identified by, I believe the Johns Hopkins. I'll send you the articles. Yeah, they did the drug checking on all the substances. Yeah. Yes, please.
Thank you both for doing this talk. I've had different opinions of benzodiazepines over the years. Just by your, and SSRIs, thanks for talking about those too and the effectiveness and stuff. But definitely you've changed my opinion, that I'll look at things differently. But the thing I'm concerned about is what you were talking about, the people that get the synthetic ones. I mean, we've had some people recently that have overdosed. They're not responding to Narcan. And I think it's either that, it's the nitazines, it's, there's other things. So to look at that, I think the thing with benzos, my understanding was always when I talk to patients is that benzodiazepines are really, recommended by CDC or, whatever for panic. And, so I try to explain to people that I think they're okay to take, especially if you're having an anxiety situation. What I find difficult in the hospital is when people come in and even if they've been prescribed on PRN at home, they come in and they prescribe them, not PRN, but just, TID, not a PRN dose. And the patients are laying there.
I don't know.
Coming in, they're giving them a benzodiazepine. And I always say to them, it's fine, but you really should take that when you're feeling anxious, but I think you were just talking about for PTSD, but are they recommended?
Or for generalized anxiety disorder.
Schedule the benzodiazepine.
No, PTSD, no. I mean, PTSD, this would be a great email, email thread, no doubt. But yes, so the thought was in PTSD, benzodiazepines are not recommended.
They reduce,
But yes, they do. Yes, this is the problem with that data.
Like stopping them just because someone overdosed, like you said, what you want to stop them from doing is going out and using stuff that we don't have any control of. And we can have control of this if we have a conversation with them and letting them know, like I said in the beginning, letting them know the risk and benefits of these medications. And, it's worth a try if they're not using street drugs, right? So anyway, but I do think the PRN is the way to go. I just can't get into the schedule.
Respect. Thank you very much. Yeah. Hi, Emily.
Hi, thanks for this. My question is kind of related to this topic. It's sort of what is the evidence for efficacy of chronic benzos for chronic conditions like generalized anxiety disorder, PTSD, which we're saying there's not. I think I've always been taught they're good sort of short-term acute PRN medications for panic disorder. They're not good long-term medications, and that's where some of the hesitation comes from. So I'm curious.
Sure. No, this is excellent. So thank you for that question. What is the evidence for long-term use of benzodiazepines? There is evidence up to 3 years of efficacy. Glad to share that data. And these are small studies because they're, as mentioned, they're off patent. No one is doing long-term studies of generalized anxiety. And I would just say, coming back to our cases yesterday of pain, these are highly individualized cases. And far be it from me to say, this is Michael and I are presenting a way of thinking about things for a given person. And for that given person, we're listening to them and walking the path with them. But in terms of long-term data, it exists up to 3 years. I'm glad to share that in terms of, and shows a positive efficacy.
Yeah, I think the tricky part too. So many of our patients have experienced trauma.
Right. I mean, this is the thing. You cannot randomize any one of our patients to an inclusion criteria and exclusion criteria. And I say this as a researcher who values research. This is hard research. And at the same time, the flip side of that is it's hard enough. We should be really cautious about blanket statements because that research wasn't done on my patients. I'll tell you that much. There are so many inclusion, exclusion criterion to let them even get in the study, that it doesn't fit the profile of many of the people we take care of. So thank you for that.
And I think practically, the situation is going to be, patient has been prescribed benzodiazepines for some period of time. Maybe they've also been taking some non-prescribed, maybe bizarre benzos. And the patient will not look good stopping the benzos unless there's a thoughtful tapering program. And that needs to be done with the patient's buy-in and a mutual trust. Because that's part of what we're talking about, is the relationship with the patient and the journey with the patient to a better health status. You know. Right. Right. So because I was off mic, the sort of your perspective has to do a lot with what your clinical situation is. If you're at an ATS or you're in an acute care hospital where patients are coming in for short periods, physiologically dependent on a benzo, that's going to feel different when you don't have continuity of care and you don't have an ongoing relationship with the patient, and the decision making is maybe going to be a little different.
I would just say, because we don't offer the patient voice nearly enough. And I want to say there's no generalized anxiety disorder constituency in the country, right? I mean, at least for the folks with chronic pain, they have some voice that they've been using to good effect and pushing back on policy. But there's no constituency for benzodiazepines, ironically, even though how prevalent they are and how at a whim they could be continued or not. And so it's just strange to me that for a medication that may be working well for someone, they are at the whim of us and our choices rather than something that works well for them. And that, I think, is more an inward-looking question to me than blaming the patient for being on something that was working. So I say this with absolute respect for what you're saying, and I think is a real flaw in healthcare. Thank you.
Hi, first of all, thank you guys. I'm going to start with a bunch of jumbled thoughts that may or may not end in an incoherent question, or at least something that you can beat me down with data over. But from 30,000 feet, the first thing I'm struck by, and maybe this is stating the obvious, is just how interesting this is as a parallel to opioid prescribing.
Yes.
And I feel like for so long, prescribers were eager to initiate, but with escalating use, to reach the point where then they were uncomfortable to continue. I think most people in this room don't want to start these medications, but also would be uncomfortable discontinuing it. And I also think about mentors over the years, in medical school 20 years ago. At that time, there were 2 geriatric psychiatrists in the state, mostly to do with reimbursement. Not that any other psychiatrist couldn't take care of older patients. And I'd say 20% of the patients that we inherited were referrals for benzotapers because of cognitive decline and other stuff and other needs to come off. Moreover, I'm sure many people here have tried to help their own patients taper off of benzos that wanted to stop and were unable to do so. So I think it's this one-way kind of fear of that on-ramp, and then the precariousness of whether they can continue prescribing long-term. I'm also, and I'm going to get the data wrong here, but I think something like 25% of all people will meet the criteria, if not GAD, of some anxiety disorder in their life. But that's transient. So I think the risk is that you could be initiated on the suboptimal treatment and then be bound by it forever. And if that's the case, don't we also then have an obligation to try to taper people off to get them to a better therapy if that's something that's not ideal post that moment when they need it? And also,
So far, the logic is.
to make
No, well, I'm gonna push back on the logic actually, because you would know if it was transient, because you would have tried an SSRI and an SNRI, CBT, and after 3 weeks, they were better. So you would never have gotten to this second line agent, I guess. I'm just trying, I'm sorry. After 3 months, no, before, what I meant to say, pulling back, I'm sorry. You get started on that. You get things going, and then 3 weeks later, like, doc, things were really stressful. I'm better now. So you would have figured out the transient part of that just by virtue of the longitudinal
transient
care.
could be months or years.
Transitory months or years seems like a contradiction in terms, so we'll have to talk about that later.
But also, I think in hearing this, I think it's important to make a distinction, like with the case studies, between those patients we inherit with, a complicated drug supply versus those that are talking about initiating it because they're borrowing their partner's benzos. And I think it's important to make that distinction. Which
No, please. This is such an important and thoughtful and rich grown-up conversation. And
Yeah.
we're all grateful.
Well, one thought which I didn't mention is the idea that you're trying to do a rational, patient-centered tapering, and maybe you hit a low level of benzodiazepines that you can't go lower than which one cannot go lower. That's okay. So long as it's safe and you're documenting safety, you've shaved off a couple of milligrams of diazepam. Wonderful. You're safe, and we'll keep working on it if that makes sense sometime in the indefinite future. Thank you.
Hi, addiction psychiatry in Holyoke. So this is my life every day. And I could talk about it for hours. So I'm going to try to be brief because I think it's so important that because I think we've all gone through a process or in a process. I don't think it ever ends as long as we're, working with our patients. First, you're learning about it. You don't really know much. And then you're like, oh my God, these are terrible and addictive. And, people, have these awful, annoying behaviors around them. And it drives me crazy. And then it's like, oh, wait a minute, I'm being too withholding and I have to manage my countertransference. And then so I've gone through all of that. I'm still suffering, every day. But seriously, like ever since I started to think about it as from a harm reduction point of view, I feel much better about how my patients are doing, how my documentation looks, how I feel about my work, because it's always both and, either or, don't know. But at the end of the day, the thing that keeps the best possible patient care and safety is I'm seeing that patient as frequently as possible. And then I know, oh, okay, you've been trying really hard, for 10 months and we got down to 8 milligrams of diazepam. We tried 6 and you felt terrible. Okay, you're at 8. She just turned 65. I'm okay with that because she's stable on buprenorphine. Awesome. I have a guy on 2 benzos because without them, he will get homicidal, literally. And so, like, none of these make sense if you look at it from like, why is she doing that? Because there are other patients for whom I would say, oh, definitely not. This is not okay for you. Because I have so many PTSD patients who are older, who were put on them iatrogenically harmed, because they didn't know, they were 16. And so it's so convoluted and hard. But I guess to conclude, because I know it's ice cream time, Ruth said so. So I read the guidelines. And I don't know, I guess because they're, coming out and saying how gradual it needs to be, which I agree with, we have to be able to incorporate that into our care model and our reimbursement model. I mean, I'm happy to see most of those patients because I know a PCP has 15 minutes and that's not okay. So I feel like that's a part of the conversation. We need to have the longitudinal relationship, the stories from the patient and really understand like where they're at. And then we can be aware of how they're doing and then prescribe accordingly.
Yes, I hear you. And just, we'll respect. Casey is up. Thank goodness.
I mean, I don't know that I actually have a question. I'm going to be honest with you. So 2 like thoughts that I had. during all of this discussion. One is actually feedback that I got from my own personal care from a nurse practitioner while I was in pharmacy school. When it came time to discuss my anxiety and all the things that I was trying and not working, and ironically, as a pharmacy student, did not want to start any meds at all, even an SSRI, nothing. Just trying to do the whole therapy thing. And she kind of advised me, and this is something that I now tell my patients, is sometimes it's okay to start a medication to help you get to the place where you can then actually go through and do the things and learn the behavioral techniques and whatever it may be. So that's something that I just find really helpful. And my other thing is just my hesitance towards benzos comes actually more from my experience over the last 6 years being a pharmacist. Patients, they're really nice to their clinicians. We should know this, I hope. They're very nice. They're very kind. They sit through, the appointments. They are not so nice to the staff and the pharmacist, especially. And I've found actually that the patients who are waiting for their benzo scripts are actually, in my experience, probably the most aggressive, and like mean. And I think it's probably because, as I was thinking through this just now, they're anxious about the fact that they may not get their script. But how do we help that though? Because it's not really fair for the rest of the people to deal with the patients who are anxious and getting screamed at and told that, they're going to go have a seizure and die.
No, look,
But I think that's just something to keep in mind when starting a benzo
No.
or just in general conversations to have. with
yes,
patients.
be a responsible prescriber was the theme of the talk. Absolutely, and be kind to your colleagues and kind to your patients. And if this was gray and patient-focused and complicated and unsettling and mutually respectful, then about a major problem, then I think Michael and I did okay if it was that way. We hope it was. If you have interest in this, or if MASAM is further interested, it sounds like people staying here may indicate that. It might be worth a second conversation or several emails. But thank you very much.